Yeah, thank you. I would be speaking on retinal detachment in a blunt trauma. Thank you, OTSA, for this wonderful opportunity. Well, we all are aware of the various mechanisms, how it happens, and predominantly these detachments, which are seen in younger patients, almost 11 to 40% of them are secondary to the trauma. And they are more so seen in high myopes with classically having GRT and nasal dialysis. The incidence varies from 3 to 6%, and classically it is seen more so in a young patient because they are more prone for injuries because of their active lifestyle and also sports and all. These are the eyes in which after receiving a trauma are more likely to develop a detachment. And what are the mechanisms? This is for the sake of postgraduate. It can be a coupe or a contra coupe, which is classically illustrated in figure. So that leads to various direction of forces leading to shearing, which can lead to retinal detachments. Classically, the most common type of a break which leads to detachment is a dialysis. In 53% of a traumatic RD, it is the dialysis which is elicited here, which might be associated with base avulsion. And if it is associated with base avulsion, a dialysis, it is pathognomic that this detachment is secondary to retinal detachment, even when the patient denies the history of having received any trauma. Round breaks are unlikely to be the reason for traumatic retinal detachments, but yes, over a period of time, sometimes what happens because of a gliosis and scarring happening in a blunt trauma, over a period of time can also lead to round breaks. Horseshoe tear is another entity type of a break in almost 11% of the patient. Usually, classically, they are seen, as you can see, at the anterior edge of the posterior edge of the lattice or at the edges of it. Most of these detachments do not present acutely, they present later. Blunt trauma, remember, less than 30% of the diagnosis, and more importantly, they present late and they're picked up late. And that is the other reason, this is the reason why you have significant delay in the diagnosis, and this further added to it by young uncooperative patients. Sometimes if they have associated systemic injuries, associated media haze, we fail to pick up the detachment. Traumatic detachment per se is associated with more significant PVR compared to a rheumatogenic retinal detachment because these patients are younger, they present late, they have associated inflammatory factors in the form of hemorrhage, inflammation, and smoking is a matter of, it has been implicated rather. As happens, you have to go ahead with a classic examination because we have to take vision. Equally important, I should say, I will just run through this slide. Most important thing is in a case of a blunt trauma, indirect ophthalmoscopy is must with indentation, and you can pick up lesions like choroidal rupture, Berlin's edema. Berlin's edema as such needs no treatment, but remember this is a retina which is edematous, which can later give away and form small holes there. This is a case of a retinal detachment associated with a displacement of a lens. And importantly, I forgot to highlight repeated examination. So in a case, a young patient who receives a trauma, as I said, might not necessarily have a holes or a detachment at the time of injury. Subsequent evaluation, say 4 weeks, 5 weeks later, and periodically following that, you will be surprised to see the development of holes because the vitreous changes which happens and leading to vitreoretinal adhesions and pull tend to manifest the detachment and the hole formation even in a later stage. I don't think I need to stress the importance of evaluation of uninvolved eye. In a hazy media, B-scan is very important, and more importantly, again I repeat here that the serial B-scan is mandatory because you have a hemorrhage, initially the detachment might not be there. So you have to do periodic serial B-scans to pick up a detachment and all, or new vitreoretinal relationship which can pick up. And how do you differentiate between a PVD and detachment? I will not run through it. Sometimes you will be surprised even if it is a blunt injury, patient says it's a case of a blunt injury, but you would pick up a foreign body. You can also, B-scan can also give you the integrity of a posterior capsule, and for that, because that will help us in deciding the type of management, whether we need associated management of a lens or not. This is a retinal detachment associated with a lens dislocated cataract. Do we need ancillary tests like CT scan and MRI? Yes. If you are not sure whether it's a blunt injury, is there an open globule, CT scan can give you what is classically called as a flat tire sign, or associated comorbidities in the form of muscle rupture or a foreign body can be picked up. Whenever the index of suspicion is high, you should not hesitate from doing these ancillary tests. So if you have a break at this stage of pickup after a trauma, simple thing is you need to do a PECSI. You can do it with the help of a cryo, or you can do with a laser. Laser leads to less inflammation, and if the media permits it, if the haze is not bad, you can definitely get away by doing a barrage laser around the breaks. But if the media is more hazy, there is a hemorrhage where you cannot reach out through the laser, then comes the role of cryopexy. If you have a detachment, the primary procedure of choice in such cases is scleral buckle. Why? Because these patients are young, they do not have PVD, there is the detachment, buccal surgeries have shown to have a superior success rate, and even if you need a resurgery, the success rate is better. So this is a classic buckle which is being done. I will just, for the want of time, this is classic, and you also put an encircling band along with a tire in the area wherever there are breaks. And this is the, I think I will just run through it. So this is the closure. Vitrectomy is done for a detachment if the detachment is associated with hemorrhage, vitreous hemorrhage, posterior tear where we cannot reach out with a buckle, or the patient which has associated dislocated cataract or a macular hole, or a PVR is more so. And when do we also add an encircling band to a vitreous surgery? When there are larger dialysis, inferior breaks, very severe anterior PVR. In such cases, you might add, along with vitrectomy, an encircling band or a belt buckle. And this is the goal of vitrectomy. You clear the media, you relieve the traction, reattach retina, and use a tamponade. The prognosis, as indicated, I will not run through it, I will just move on. So what are the prognostic factors? Whether you can manage with a scleral buckle or an encircling band, the iatrogenic breaks, the need of tamponade, and need of lensectomy. So if you need lensectomy or a tamponade, naturally the severity of injury is more, and so is the prognosis less. Now this is a patient who had a detachment, high myope patient who had a 270-degree giant retinal tear. So here we begin, you can see the anterior flap of the giant retinal tear blocking the infusion port. So that is what I am trimming. And after I do vitrectomy, in most of these cases, the posterior vitreous detachment is complete. So I unfold it with the help of a perfluorocarbon. Now I am shaving off the anterior vitreous and the anterior flap. I am eating off with the vitreous cutter, because if you leave a redundant anterior flap, it leads to more PVR and sometimes it causes neovascularization. You can see the ciliary processes over here. Okay, so this is we are doing with the help of a 3D surgery. And now I remove the PFCL bubble. I decide to do an ILM peel for the macula. Macular peel I do, and following that, once I complete that, the laser, again I put the PFCL, do a laser, and a tamponade is put. This traumatic retinal detachment is associated also with a large macular hole. So in these cases, if a significant PVR is also there. So in a classic case of a macular hole, what you do is you complete vitrectomy, you peel the internal limiting membrane or stuff it into the macular hole. Here the challenge is the hole is not necessarily only because of a tangential traction. There is a significant PVR in the periphery which is leading to contraction of the retina. So in such cases, tackling the peripheral PVR is equally important, and that can be in the form of just membrane peels, or sometimes you also do it as you can see, I have done a retinectomy for this patient. So this is another case of traumatic retinal detachment with old GRT. Now, as I said, sometimes it is also associated with comorbidities in the form of a subluxated cataract, which also need concomitant management, as you can see. So after doing vitrectomy, I am doing lensectomy. The challenge of doing lensectomy in such cases is that the retina is very mobile, and it tends to come into your active ports of fragmatome. And you have to be very careful. You have to get the lens into the mid-vitreous cavity or almost into antivitreous and stay away so that you don't create iatrogenic breaks. Now this is another comorbidity. You can see you have a lens detachment along with the IOL. So this adds further to the complexity of the such surgery. So you have to remove the IOL as well after doing a vitrectomy, and then suture the corneal wound through which the lens comes out. And after that, you have to do the surgery. As you can see, I have removed the lens, and the rest part is almost similar. While this is an open phaco wound because of a blunt trauma. So remember, whenever you have a blunt trauma, especially in an operated eye, the first place where whether it is a closed globe or an open globe, if you want to ascertain, look at the wound site wherever the phaco or a cataract surgery is done, and most of the time your diagnosis would change from a closed globe injury to an open globe. So to summarize, 11 to 40% of rhegmatogenous retinal detachments which we see in our practice are secondary to trauma. Classically they happen in a young patients where they manifest late, they have a delayed diagnosis, they have more severe PAVR, and that's the reason why many a times the prognosis is lesser. Dialysis and giant retinal tears are the type of breaks which are more commoner in a traumatic retinal detachment. Whenever you screen for a blunt trauma, remember indirect ophthalmoscopy is the only way to look at it. Sclera and buccal still is the procedure of choice, primary procedure of choice, unless associated comorbidity in the form of PVR, macular hole, dislocation of lens. And you importantly need to also tackle associated comorbidities, and in such cases you do a vitreous surgery. Thank you.
Thank you, Prashant, for that excellent summarization and excellent presentation, very well illustrated with videos.
Sir, I will make one announcement with your permission.
Yeah.
ARC has decided to go ahead with OTSI and launch a CME series on ocular trauma, which would be like a coffee book table. And with your permission, I have decided Mrs. Shah to be the lead author, and we are inviting the younger people to contribute to the chapters.
Great.
And the senior people will be the mentoring those authors, and they will be and we will create a coffee book table which will be on everyone's table for their clinical practice.
Thank you.
Thank
That's a great measure.
Prashant,
Now first, one question, Prashant, before I hand over to the two of you. What are the three commonest causes of decreased vision after blunt trauma attributable to posterior segment? And then I hand over to the two of you.
Okay. So the commonest reason, I don't know the statistics point of view, but one is the traumatic macular edema. Second is sometimes
sequelae of
blunt traumas. Yeah, one is that one you can expect is a choroidal tear, and third is of course a detachment which later on manifests, or a traumatic submacular hemorrhage, or whatever we can call. Madam, can you add something? I don't know the sequence statistics point of view, incidence wise.
Vitreous hemorrhage.
Yeah.
Let's say persistent poor vision or persistent decreased vision, say 1 month or 2 months post-operative.
Yeah, then it's a traumatic macular edema leading to an atrophy or an hole or an epiretinal membrane formation, sometimes a choroidal tear.
Macular hole?
Yeah, macular hole. Yeah, that all becomes into the same.
In a situation where you find, you take the patient in, and on exploration, you may find the scleral rupture.
Yeah, it's not
Then
uncommon.
it's very common. But what do you plan? You suture the rupture and defer the retinal surgery, or you continue with this during the same CT?
No, it depends upon, see, concomitant means you are talking about primary surgery versus a planned surgery for a vitreous. There are multiple things which come into the play. The primary thing is if it is an open globe injury and associated with retinal comorbidity, and we are planning to do 2 procedures, whether it can be at a single step or a 2-step, that is what the question is, correct? So if the wound is away from the visual axis and I can achieve a good, a proper closure of the wound which will prevent leakage during the surgery, I would like to do it, especially in cases where I fear infection or the type of a foreign bodies which can lead to more inflammation. But if not, I would like to primarily close and then take at a second step, say about 7 to 10 days later. But the message which should go across is that whenever you do a wound repair, please do not refer it to the vitreoretinal surgeon, say about 3 weeks, 4 weeks, 5 weeks later. They have to be referred within 7 to 10 days, because that is an ideal window when you get the best of the success when we as a vitreoretinal surgeons go inside and do surgery.
By that time, the EVD has also taken.
EVD has happened, and otherwise what happens if the patients are referred after 2 to 3 weeks, the PVR is so severe that many a times we have to abandon the case. We may not be necessarily able to open the funnel.
That criteria, I think, is changed. 100 hours
Yeah,
second surgery.
correct.
About
Karobi.
14 days would be the ideal time
Maximum.
to go in for the second
Yeah.
time. And mostly it is a two-step thing, but if you see that thing of hemorrhage over the conjunctiva transgressing into the orbit, you know that there is a scleral rupture, so always at the first thing you have to open
Open.
it back and suture it. There was one thing which I wanted to highlight is that one indication which you should have touched is that of a shaken baby syndrome.
Okay.
Because this is one aspect of a blunt trauma where there is no history of injury. Nobody knows how it has happened, but the child suddenly becomes comatose. 80% develop a lot of hemorrhages, but in a lot of patients you do get changes in the retina where retinal detachment, etc. also occurs along with it. So that is something which requires mention.
Yeah.
Because that's,
How commonly do we see it?
in my practice of 33 years, I've seen 7 patients. And they have to be
what
picked
is
up
your-
because there's never any
I did not
history.
see any patient.
What
There's
about
never any
Prashant?
history because you have to dig for the history.
Prashant, any cases seen?
Seriously, I know she's very passionate about the pediatric cases and she picks up, but probably I might have missed in a busy OPD. Very truly said by Dr. Kairobi that probably we really don't look into it, or probably we are not oriented to look for it, I believe.
Yeah.
I accept that.
Actually, the thing is that this is a problem where, like, the police forces and all have to be sort of
Alerted.
yes, but in our country, sadly to say, that even if it is a frank case, no action is taken. Absolutely no action. They just cover it with dust, so it's really bad. Prashant, do you use general anesthesia for examining any of your patients of the pediatric age group, or do you do it without? The peripheral examination which you have to do maybe
Yeah.
3 weeks later, 4 weeks later.
Frankly speaking, it's a very subjective decision. You try to do an indirect ophthalmoscopy if the patient is not allowing you. You try, I know it might sound a bit harsh. We used 2 Desmas retractor and tried to see at least up to the equator and beyond. If we see that it is comfortable enough and we can avoid anesthesia at that point of time, I might even not worry about it. But because you need to get tide over the initial phase of, after trauma, that patients also cool down. But yes, if it is associated with a significant vitreous hemorrhage and I am feeling something is fishy, that is the time probably I might subject him to general anesthesia just for diagnosis.
We do the EUA.
Okay. Thank you.
Thank you.
At the outset,